Today I'm going to talk a little bit about a study that we performed here at the University of Iowa as part of our neuroendocrine tumor spore project, specifically about trying to find novel drug targets and repurposing certain therapeutics to try to better treat this entity, pancreatic neuroendocrine tumors. So just as a quick disclaimer, I have no financial conflicts of interest, and I will be discussing the potential off-label use of a few FDA-approved oncology medications, but just in an in vitro setting in this talk. So, pancreatic neuroendocrine tumors. If you haven't heard of these tumors before, that's not too surprising. They are relatively uncommon. However, they have taken from us a few very valued members of the global community, including both Steve Jobs and Aretha Franklin. So they account for less than 3% of the pancreatic tumors. So obviously the more aggressive form, the adenocarcinoma type, is what accounts for the majority of those. However, what is interesting is that the incidence of pancreatic neuroendocrine tumors, or PNETs, has increased in recent years. So these are slow-growing tumors. They usually have a pretty favorable prognosis, but because of that slow-growing, indolent nature, diagnosis of these tends to be delayed, and as a result, about 60% of the patients, when they present with this, when they're actually diagnosed, the tumor has already metastasized. And when these tumors metastasize, they commonly go to the liver and the lymph nodes, and unfortunately, despite advances in treatment in this over the last several years, the majority of patients will die from this disease. And unfortunately, despite the fact that we have many new therapies for this condition, they do not typically improve overall survival. So we do need to identify new therapeutic targets and perform clinical trials on new drugs. So I want to talk to you again about a specific study that we performed here at the University of Iowa, and that was published in Clinical Cancer Research earlier this year. So our goal of this study was to find a metastatic gene signature for metastatic PNETs from which we could identify drug targetable regulators. So in order to do this, we compared gene expression profiles between metastatic PNETs and primary tumor PNETs. One nice thing about this is that it does not require a, quote, normal tissue sample, which in this field is sometimes challenging to acquire, as these tumors are often derived or almost exclusively derived from neuroendocrine cells, such as the islet cells in the pancreas, which can be kind of hard to dissect out. So in this particular study, we looked at 39 primary tumors. So those were kind of, if you would say, our normal tissues. 21 metastatic PNETs that metastasized to the lymph nodes, and then also 17 that metastasized to the liver. So part of the reason for using these two different sites was to try to identify a very consistent gene expression profile that would be related to metastasis. And what we wanted to do was try to use that gene signature to predict what therapeutics would work best and to test that in vitro. And as you can see here, that after we performed the RNA-seq, we created a 626 gene metastatic expression profile, which we then analyzed using two different platforms, CMAP and IPA, to identify these novel drug targets and then perform in vitro drug testing. So when we first performed the RNA-seq and the differential gene expression analysis, between just all of the metastatic tumors versus all of the primary tumors, we had about 902 differentially expressed genes. But when we clustered these and looked at these in a heat map, we started to see that there did seem to be some pretty prominent tissue-specific gene expression changes. So you can see up there at the top, let's see, I think I might be able to get there we go. So you can see up here, a pretty bright red block right here of upregulated genes that seems to be very specific to just those metastatic tumors that metastasize to the liver. And you can also see a couple of other blocks as well. So when we first saw this, we were a little concerned that there might be something that we're observing that's much more tissue specific as opposed to metastasis specific. And when we looked at the individual genes that were present, they were, the ones that were the most highly expressed genes. We were kind of surprised to see that they were really, especially those that were the metastatic tumors in the liver, they were kind of all related to just normal hepatic metabolism and coagulation. So things like certain blood factor, coagulation factors, or proteins like albumin. And we didn't see quite as much of this in the lymph node metastases, but this was still pretty striking. So when we did principal component analysis on the gene expression data here, we saw very clearly that we were looking at a tissue-specific effect. So you can see here that the blue liver metastatic samples tend to kind of all cluster together compared to the others. So there seems to be something very specific about these liver metastases that separates them from the rest. And we were a little worried about how this might influence any downstream pathway analysis or potential drug selection. So one of the things we used IPA for in this study was to further explore this particular finding. So we performed core analyses and where we looked at things like canonical pathways and upstream regulators to see what might be being enriched for in these liver mets. And then we also used the analysis match feature to identify other gene expression experiments that are similar to what we were seeing in the liver metastases. So when we looked at the canonical pathways, we were not entirely surprised to see that there were a lot of pathways related to drug or other compound metabolism or degradation, things that are functions that are very specific to liver metabolism. When we looked at the upstream regulators, we also saw that many of the highest scoring and activated regulators were those involved.
QIAGEN.
Sample to insight.